Dear Chair, dear audience, please let me to introduce you my PhD thesis title, which is Management Strategies for Patients with Valvular Heart Disease. My name is Adolf Lichtfusz, and I'm a PhD student at the Central Hospital of Northern Pest, and my vision is that every patient with valvular heart disease should have an individualized treatment strategy. And my mission is to clarify the best treatment plan for each subgroup of these patients. To achieve my mission, I have two ongoing projects. The first project is assessing the effectiveness of transcatheter mitral valve repair or left ventricular reverse remodeling in heart failure. Heart failure affects more than 64 million people worldwide, and mitral regurgitation is the most common valvular heart disease in heart failure patients, affecting almost 65% of patients with chronic heart failure and 50% of those with acute heart failure. Transcatheter mitral valve repair, or TMVR, is a possible therapeutic option for patients with severe mitral regurgitation with high risk for surgical valve repair. So our aim is to evaluate to what degree the TMVR procedure slows heart failure progression by measuring its effectiveness on left ventricular remodeling. Our first clinical question is the following: how transcatheter mitral valve repair influence heart failure progression? Our population is heart failure patients with mitral regurgitation, and we would like to see the change in echocardiographic parameters from baseline to follow-up in patients who went through the TMVR procedure. And our secondary outcomes are NT-proBNP and mitral regurgitation. So we hypothesize that transcatheter mitral valve repair causes left ventricular remodeling. And we have a second clinical question, which is the following: is transcatheter mitral valve repair more effective than pharmacological therapy in slowing heart failure progression? Here the population is heart failure patients with mitral regurgitation, and we would like to compare the TMVR technique to the guideline-derived medical therapy. Our primary outcomes are echocardiographic parameters, and our secondary outcomes are NT-proBNP and mitral regurgitation. We hypothesize that transcatheter mitral valve repair has a superiority in effectiveness on left ventricular remodeling compared to guideline-derived medical therapy. Here you can see that we conducted a systematic search in 3 online databases, and down here you can see our search key. The first part of the search key is about the mitral regurgitation, and the second part is about the TMVR technique. We started with more than 9,000 articles and ended up with 38 articles. Before I show you my results, I would like to say a few words about reverse remodeling, which is very important in the point of view of the prognosis and rehospitalization rate. So in heart failure, the architecture of the heart muscle changes and the chambers dilate. With adequate treatment, we can reverse this process and shrink the chambers. This we call reverse remodeling. The guidelines say that at least a 10% improvement we can call clinically relevant reverse remodeling. First, I would like to show you the technical success rate of the technique. Here you can see the grade 3 proportion mitral regurgitations before the procedure, which was 99%, and here you can see that after the procedure it is only 9%. So we can see that the technique is technically successful. Because we have so many echocardiographic parameters, we summarized the parameters in a table. Here you can see that although we had statistically significant results, the clinical relevance was low. We did the same with the comparison with the TMVR to guideline-derived medical therapy. Here you can see that the clinical relevance was low and statistically was not significant. The first analyzed parameter is left ventricular end-diastolic diameter. We measure it in millimeters, and we used for our statistical analysis mean difference. We used mean difference for all of our plot. The heterogeneity between studies was high, and the mean difference was minus 1.63, which was, although statistically significant, clinically it was not relevant. On the second plot, you can see the comparison between the TMVR to the guideline-derived medical therapy. Here, the heterogeneity was 0%, and the difference was minus 1.02, which was not clinically relevant, neither statistically significant. Here you can see our second parameter, which is left ventricular end-diastolic volume. We measure it in milliliters, and the heterogeneity between studies was moderate, and the mean difference was minus 14.21, which was, although statistically significant, it was clinically questionable. On the second plot, you can see the comparison between the two treatment strategies. The heterogeneity was moderate, and we had a difference of minus 5.29, which was clinically not relevant nor statistically significant. The left atrial volume, we measure it in milliliters, and the heterogeneity between studies was high, and the mean difference was minus 5.70, which was not clinically relevant, neither statistically significant. And our last parameter is NT-proBNP. The heterogeneity here was moderate, and we had minus 1,340 decrease in NT-proBNP, which was a clinically relevant and statistically significant improvement. Our study has strengths and limitations. The strengths are high patient number, many different follow-up periods, and unique study design. For the limitations, we can say that we had only 2 RCTs and a few studies with long-term follow-up, more than 12 months. So as conclusion, we can say that although TMVR procedure was technically successful, there was no clinically relevant change in the main echocardiographic parameters, nor any significant difference in cardiac remodeling favoring TMVR. We would like to recommend the implication for practice that the benefits of the TMVR procedure in cardiac reverse remodeling may be limited, and identifying which patients benefit more from TMVR and explore other factors influencing its effectiveness is important. Also, high-quality randomized controlled trials are needed. Here you can see my first project progress. I am almost done with the method section. My second topic is investigating the predictive value of risk factors for subclinical leaflet thrombosis after transcatheter aortic valve implantation. It's also a systematic review and meta-analysis. Diseases of the aortic valve account for more than 60% of all valvular heart disease deaths, and transcatheter aortic valve implantation, or TAVI, is a revolutionary treatment for severe aortic stenosis, extending from high risk to lower risk patients. Subclinical leaflet thrombosis can affect more than 25% of patients within the first year following TAVI, and it can evaluate into symptomatic thrombosis or premature bioprosthesis degeneration, causing fatal neurological complications. So our aim is to assess the best prediction factors and biomarkers which could anticipate leaflet thrombosis after TAVI. Our clinical question is, what are the most effective predictors and biomarkers to enable early diagnosis and prevention of subclinical leaflet thrombosis after TAVI? Our population is patients undergoing TAVI. Our risk factors are gender, comorbidities, procedure-related predictors, and blood-based biomarkers and imaging findings. And our outcome parameters are incidence of valve leaflet thrombosis. So we hypothesize that the identification and utilization of effective predictors and biomarkers can lead to early diagnosis and prevention of subclinical valve leaflet thrombosis. Clinicians can use this data to enhance the customization of post-procedure antiplatelet and anticoagulation therapy for improved treatment outcomes. For summary, here you can see my 2 ongoing projects. The first one I plan to submit in June, and the second one in September. Thank you for your attention. Research is to see what everybody else has seen and to think what nobody else has thought. Albert Szent-Györgyi. Thank you.
What kind of devices were used in the TMVR studies?
The mitral clip device and the Pascal device, but with the Pascal device we have only one study.
Only one?
Yes.
And do you have any data on the first operational success rate in these studies with the mitral clip and the Pascal?
Yes, it was 99% successful, the procedure. In the technical aspect, that the grade 3 proportion reduced a lot, significantly. So it was technically successful, and it was successful on the hard endpoints too.
Yeah, okay, thank you.
Dear Adolf, we were waiting your data about NT-proBNP levels.
Yeah.
And is there any difference between the investigation group and and the TMVR group.
Yes, sadly, these studies, for my surprise too, didn't check the NT-proBNP. So we had only 4 studies which checked NT-proBNP, and these were only baseline to follow-up studies. So in the comparison studies, we didn't have NT-proBNP to analyze it enough. Yes,
data.
but it would be very interesting to see the NT-proBNP levels in more studies.
Thank you very much.
Thank you.